Hello and welcome to the eCatalyst 2021 E&M Guideline Changes. My name is Julie Seaman. I'm the Director of Coding, CDI, and Compliance for eCatalyst. Today I'm going to talk a little bit about the E&M changes that go into effect on January 1st of 2021. Okay, so starting out, I'll give you a little bit of background onto the guideline changes. We've had guidelines from CMS on E&M codes since 1995 and 1997. A lot of these guidelines really put a lot of onerous documentation requirements on the physicians or providers. And so there's been a process in place for the last several years to update these guidelines. There were some changes that were set to go into place a couple of years ago, and they were really kind of scrapped and started all over with an editorial panel from the AMA. And so some of the reasons why this panel was created to change the guidelines were because there needed to be a decrease in the administrative burden of documentation on physicians. Right now, the documentation requirements are so burdensome on the physician. The amount of documentation that they're doing that it really isn't helping in care of the patient is abundant and unnecessary. So they wanted to kind of put in some guideline requirements that are more up to date based on the use of the electronic health record. Also, we want to decrease the amount of audits. Right now, CMS does quite extensive audits on evaluation and management services because there are so many requirements with the current guidelines. In addition, the amount of documentation in the medical record is really not needed for patient care. A lot of my clients have called it note bloat or some just unnecessary documentation that really doesn't help in patient care. It really is just there to meet the requirements, checking off those boxes and making sure everything is there that is not necessary. The other part is to ensure that the payment is more resource-based. It's really based on the physician work and resources used as opposed to kind of documentation, so checking off those boxes that really shouldn't be the way that these services are paid for. So the big changes are they're going to eliminate history and physical as elements for code selection. So it's not to say that history and exam are no longer needed at all. They should just be based on the medical necessity, what's medically appropriate based on the patient's current condition, and what needs to really be in the chart appropriate for patient care. So the history and physical exam are no longer part of the selection requirements for E&Ms. Moving forward, they're going to be able to select the level of E&M based on either time or medical decision making. And that really does really create a resource-based selection of E&M services and a resource-based payment model. So time is not just time spent with the patient, but there are quite an extensive list of activities that are included in the amount of time. And then medical decision making, they've gone through and updated the medical decision making. And so we'll talk a lot about what's required and what is included in the medical decision making. So what did they do? They took some modifications. They took the initial CMS table of risk kind of as the foundation for the new medical decision making guidelines. They removed things that were more ambiguous or more gray and made things a little bit more easy to define. They defined terms and they made the types of conditions that we're looking at better defined and with examples and really lists of criteria. So defining acute or chronic illness with systemic symptoms, taking out mild or moderate and replacing it with more concrete concepts. They did things like defining key terms. So independent historian is now defined right in the guidelines. They redefined the data element to focus on tasks that affect management of the patient. So independent interpretation of a test performed by another provider, discussion of test results with an external physician or external qualified health professional. They took away redundant code. So 99201, which is the level 1 new patient, was removed because it has the same level of medical decision making as a 99202. Both straightforward, and so instead they removed the lower level code to kind of streamline things. They created a shorter prolonged service. So in the past, the physician had to do an hour of prolonged service really to get to that next level. Now it's only 15 minutes, and they're reported only with the highest level of service. So when we talk a little bit more about history or exam. Office or other outpatient services do include the history or exam. They're not saying that a physician doesn't need to document history exam. They just want it to be medically appropriate. And that medically appropriate level of history and exam required is defined by the physician themselves or the qualified health professional. Reporting the E&M determines the nature and extent of the history and exam for a particular service. So it depends on what that patient presents with. What is the presenting problem? What is the level of uncertainty in the diagnosis that needs an additional exam or additional history? And that's how they should determine what is documented. The great news, I know that a lot of people were looking forward to this piece of it, is the care team can collect any of the history because again, it's not used for the level of service, neither is the exam. The history can be collected by anyone in the care team. It can even be collected through the patient or through an independent historian. So somebody outside of the patient's family or caregiver can provide the history. They can use a portal or a questionnaire. So I don't know how many of you filled out questionnaire on a portal for your physician before going into the visit. That can be linked right into the visit. The physician does not have to redocument anything. They don't have to document that they reviewed it. It's just it can become part of the record. The physician must review the information, but they don't have to redocument it. They just need to review it. Instructions for selecting a level of service. So this is where it becomes super basic. The level of medical decision making or the total time. Either one, whichever comes out better for the physician. So defining a qualified healthcare professional, they talk a lot about QHP in the guidelines. So a qualified healthcare professional is defined as a physician or other qualified healthcare professional is an individual who is qualified by education, training, licensure, or regulation and facility privileging, who performs a professional service within their scope of practice and independently reports that professional service. So some examples are nurse practitioner, certified nurse specialist, a PA, a certified nurse midwife, a physical therapist, a social worker, or a CRNA. All of those people can be considered a QHP, so they can document and bill for evaluation and management services. As long as it's within their scope of practice, they've been privileged, if needed, to do that service. Time. How do we define time? So the total time can be used alone to select the level of service. It includes face-to-face time, non-face-to-face time. Time spent on services reported separately are not included, of course. Anything that is separately reportable, we're not going to include in the time. But there are a whole list of activities, and we'll go over that list, included in the amount of time. One of the big aspects of this is that counseling and coordination of care are no longer needed to be greater, 50% or greater, in order to support that visit. So in the past, counseling or coordination of care needed to be 50% of the total time in order for us to bill based on time. That is no longer a factor. Now we can bill solely based on time, no matter what the visit entails. Another big change is split shared visits. In the past, CMS has said that they will not allow split or shared visits in the outpatient setting. They are now being allowed in office or outpatient setting, and they can be performed based on time or, of course, medical decision making. But if you're doing a split shared visit based on time, you're adding up the total time spent by the physician and or any other qualified healthcare provider for that same patient. Obviously, if the physician and the other qualified healthcare professional is spending time together with the patient, we're only going to count that time once. But if they're spending time on different activities, we're going to add up their total time. So here's the list of activities for time. So any preparation to see the patient. So I know there are a lot of physicians, especially specialists or for new patient visits, those kinds of things where they're spending a lot of time preparing to see the patient. So reviewing test results, reviewing old history, looking at maybe looking at an actual specimen, or looking at an actual radiology test, so looking at the CT, looking at an MRI, and coming up with their own interpretation. All of that preparation to see the patient can be included in the total time of the visit. When we're looking at total time, we're looking at time spent on the date of the face-to-face visit. There is also an option for billing for prolonged services outside of the date of service, so either before or after that date of the face-to-face visit. So that time matters and can be captured in other services. But when we're talking about the time for the E&M, we are looking at just time spent on the date of the face-to-face visit. So obtaining and reviewing separate obtained history. So if a caregiver, for example, can't be there and the physician has to call that caregiver before the visit to get some history, that time can be included. Performing of course, examination or evaluation, counseling and educating the patient, the family, or the caregiver, ordering medication, tests, or procedures, referring and communicating with other healthcare professionals, documenting clinical information. So that is huge. All this time that physicians spend documenting in the record, that also can be included in the total time of the visit. Independently interpreting results. If they choose to independently interpret an MRI, or they are going to look at an actual slide for a pathology test, or they're going to look at the lab results themselves, they can include that time in the total time of the visit. And so, as well as care coordination. Now, one thing to keep in mind is if you're separately reporting those services, they're not part of the total time. That time needs to be carved out. But otherwise, the total time is any of these activities. So medical decision making is anything that work that a physician is doing to establish a diagnosis. So there are still three components of medical decision making: the number and complexity of the problem the physician addresses during the E&M visit, and that includes, all of those differential diagnoses, any comorbidities that they're considering, underlying diseases. The next piece is the amount and or complexity of data to be reviewed and analyzed. Again, so we have three categories of data: any tests, documents, and orders, or independent historians, independent test interpretations, and then discussion of management or test interpretation with an external provider. The risk of complications of morbidity or mortality. This is again the table of risk. It really is very similar to the CMS table of risk that we've used in the past. Here's some definitions for the medical decision making. So again, it's based on the level of service, and it's based on 2 out of 3 elements of medical decision making, and it's based on those 3 components that we just talked about. This is a sample from the medical decision making table. Shows what a level 3 would look like. And of course, where the level 3 includes the assessment requiring an independent historian. And again, and what types of tests or documentation needs to be there, specifically to that limited amount of complexity of data to be reviewed, or the low number of and complexity of problems addressed, and of course the low risk of morbidity or mortality. This is an excerpt from the table, from the AMA table for definitions of acute and chronic illnesses. So acute uncomplicated illness or injury, we've got some examples here: cystitis, allergic rhinitis, a simple sprain. We've got stable chronic illnesses, so well-controlled hypertension, non-insulin dependent diabetes, cataracts. And then acute or chronic illness or injury that poses a threat to life or bodily function, an acute MI, a pulmonary embolus, a severe respiratory distress. So again, we have a lot of specifics, some just specific descriptions, and then examples. Services reported separately. Again, if anything is able to be reported separately, we would not include it in the total time. So things like a performance or an interpretation of a diagnostic test, anything that the physician is going to bill for. So here's a table for the E&M requirements for new patients. Again, it gives you medical decision making and total time in minutes. It's either or. We do not need both. It's just one or the other. Same with our established patients. So again, the level 1 is used when clinical staff members perform a face-to-face visit under supervision. It's not considered a physician visit. And then we've got our 2 through 5 with, again, the level of medical decision making and the total minutes. Again, it's either or. Prolonged service codes, we have codes 99354 and 355. Those are no longer to be used with office or outpatient E&Ms. And we've added 2 new codes. So one is a time-based code, 99XXX, and one for complex visits, which is GPC1X. The 99XXX is for each 15 minutes of additional time used on top of the total time for either a 99205 or a 99215. All work must be on the same date as the face-to-face visit. And then if it's on a different date, there are other prolonged services, so 99358 and 359 would be used. Here's a table for the new patients. Again, it shows you, less than 75 minutes, we're not adding a prolonged service. 75 to 89 minutes, we're adding 1 unit. 90 to 104 is 2, and then 105 or more is 3, and then an additional unit for each 15 minutes. The same for established patients. Again, 55 minutes, not reported separately, but then if you get up to 55 to 69, it's 1 unit, 70 to 84 is 2, and 85 or more is 3, with another unit for each 15 minutes. The additional prolonged service code is the GPC1X. This is only for Medicare patients, and it's used for the care of a single serious or complex chronic condition. CMS is actually requesting public comment regarding how to clarify the definition for this, and so we're waiting on the final rule for some more information. So how does this impact you? Is your documentation currently sufficient enough to assign the appropriate level of code? Will reportable quality measures be impacted by the changes in documentation requirements? How is time currently captured in your EMR? Does it support the new guidelines? Are your templates set up to capture required documentation such as total time? Here is a table of the work RVUs for 2020 versus 2021. As you can see, the 99202 stayed the same, and so did the 99211. All of the rest of them had a significant increase in work RVU. And we've provided the work RVUs for the new prolonged services as well. Okay, thank you so much for joining us today to talk about the 2021 E&M changes. Should you need any assistance with your transition to the 2021 E&M services, we are happy to help, and you can please reach out to Chris Myers. I've provided her contact information right here. Also, we provide quite an extensive coding, auditing, consulting services, provider education. We can provide a whole range of services to help you out, especially in this transition, but really with any other services as well. Again, thank you very much.